We'll start the PowerPoint. And, if this really isn't the information you were hoping for, just, feel free to stop me and say, and just ask specific questions. But I'll go through this quickly. You met both of us, Dr. Chia and myself.
Call me Chris.
Yes, he'll make you call you Chris. I mainly have worked, I'm a physician assistant. I mainly have worked in plastic surgery and have had a role with InMode since 2015. So lots of experience doing these, and I'm open to any questions, comments you guys have.
I practice in New York City with Spiro Theodoro. Many of you know that the CMO of the company as well. We've been involved with InMode back in the days of Invasive in 2008, 2007, all the way to currently. If there's any questions, please refer. Hilda has my contact information. Feel free to disseminate that. Okay, without further ado.
So we have Hilda. Who else is on the call with us?
With Kate.
Hi, this is
Hi,
Kate from Korea.
Oh,
Hi.
Hello.
Yeah. Hello.
Nice to see you.
Okay. Yeah, I'm good, and then I hope all of you are keeping well and safe from COVID.
You as well. A quick question. Do you have the first generation device where you have the external temperature only, or do you have both internal and external sensors?
In Korea, we have we are under the registering for the dual sensor. So we have only the first generation of the body touch in Korea.
Okay.
Okay.
Well, I think for today's purposes that it'll be universal, but I just want to ask that out of my own curiosity. Okay.
Okay. Great.
And is from on today our Korean distributor is the clinical training. 3 ladies will join us.
Okay. We'll just move along, and then we'll welcome them as they join. Excellent.
Okay.
Great, Lisa.
Okay, thank you.
Thank you.
And can you see our screen?
Yeah.
Okay, great. All right, so I'm not sure actually which devices you are using. These are the devices we're using here in the US. So we have mainly 3 different hand pieces: the BodyTite, FaceTite, and AccuTite. Do you have all 3 of those devices?
I think so.
Yeah, we have all of them.
Yep.
Okay,
Yeah.
great, perfect. Go ahead, next slide.
Mm-hmm.
All right, we'll talk a little bit about pre-treatment. So, typical, I just put these in here, typical contraindications. I know you guys have all of these. The main thing is pacemaker defibrillator. That's a significant contraindication. These are all things that you'll go through in your pre-op. The nurses will go through in their pre-op with the patient, their history and physical. Go ahead, the next slide. Keep going. All right, so I would say once the staff gets involved, photographs are really important. Pre-photographs, A, knowing how to do them, and B, being very consistent with them. That's something we actually have a webinar archived in our InMode resources that talks all about photography, which is a good resource. PO pain meds, so whatever you do for pain control, whether it's having anesthesia or just oral pain meds. We have something here in the US with nitrous, so called Pronox. That's used a lot for our awake cases. The surgeon will then, mark the treatment areas. You want to make sure, these are all things that you'll cue them to do as you're going along. Plan the incision areas, prep in a sterile fashion. We have all of our. If we can go to camera 3 for a second.
Sure.
We have all of our sterile items here that we can go through anything as far as sterile technique with you guys. What our typical setup is. That's what I'll plan on doing at some point today. All right, and here's the list of common supplies. This will be on a couple different pages. And again, Hilda, I can send this to you. We transfer this PowerPoint to you. So this is a typical setup. Some things you have maybe slightly different, but this is a typical tumescent. The setup is really minimal for this. Keep going, next slide.
Mm-hmm. Yeah, we'll go over this in detail when we open the packs. And basically cook what you can or autoclave what you can, and then we minimize the disposals. I'm sure that's a universal thing to keep the cost down. And then things that are specific to the body tight, AccuTite, face tight, we're all familiar with the gel and everything else. But basically, we're just going to go ahead and cover everything. If you think it's redundant, please tell us to speed along, and we're happy to. But we wanted to err on the side of inclusivity, and we're going to go over all these things. Lisa will open the packs as we go along. So we'll just
if that's something you need.
Mm-hmm.
Next slide. All right. So these are some of the common things that happen in the OR or in the procedure room. So when you turn your device on, you'll have an on switch in the front, on switch in the back, of course. Sometimes the gray cord in the back comes undone, and that tends to be a common call to customer service is my device won't turn on. It's really the cord in the back sometimes comes out. The other key thing that can happen.
You should put the wrong password in.
I did, yes, exactly. Is that if the handpiece isn't connected completely secure, you'll get a handpiece error. And there are all kinds of handpiece error codes. Sometimes it's a temperature error. In the manual, I always refer when I'm training everyone to the operator manual because all of those error codes are there. Another little tip that I do is I have the places that I train, I have them put a customer care number like on a label on their device. So if they're in a case in the operating room and something goes wrong and they can't figure it out, they have a number to call. So they're not running around trying to, figure out who to call. Let's see. We'll go through
error codes. Yeah.
We'll go through specific error codes. Sometimes, especially with the face tight device, if it's not connected securely, you'll definitely get error codes. There has been some low temperature cords, low temperature sensors with this also. If that happens, just instruct them, try all the troubleshooting, try taking it out, turning it off, turning it back on, replugging it in. If that doesn't work, then tell them, always have additional handpieces ready. I mean, I at least have 3 handpieces for every case I'm doing, just because you never know what's going to happen.
How about when the surgeon wants to switch from a different handpiece to handpiece? You taught me a trick on how to save some time.
Right. So if you have a handpiece plugged in, and you unplug it, the whole machine will shut down. So you want to go back to the main menu, the screen here, and
then
why
don't you go ahead and I'll open one for you. You can just do it.
Okay, I was going to do all that when I get to the
Okay, we'll do it.
Okay.
All right.
All right.
You want to move it later? Yeah, we can do it later.
Next slide.
Yeah.
All right, further supplies here. I did put some resources on here of specific cannulas that I get. If I'm training someone who is specifically facial plastics, then I like the smaller cannulas, smaller length and smaller diameter. So I put a resource on there, and you guys will have my email address. Feel free you can contact me with any questions. Other equipment is on there as well. Go ahead to the next slide. Typical setup, really, this just as a reminder, as it's case dependent. If you're doing a smaller case, you don't really need nearly as much setup as the list that I provided you. All right, in preoperative, of course, H&P, if labs are necessary. These are typical PO meds that Dr. Chia uses: diazepam, hydrocodone, antibiotic. If the surgeon is typically providing an antibiotic for liposuction, I recommend that they do similar things. you don't need an IV access. And again, the Pronox is our nitrous oxide. That's 50% nitrous, 50% oxygen.
There's patient demand, so it's not continuous, such as dental nitrous, which is 70% nitrous.
All right, for a typical case. This is a typical tumescent solution.
This will be up to the physician, but I think the
Yes.
staff should be cognizant of the lidocaine load.
Always be aware of lidocaine toxicity. You know, it's best to have double, triple checks from all the staff and the physician to keep the patient safe.
And I'm sorry to interrupt you, Lisa, but in the States, there's a couple cases where there were poor outcomes just in tumescent local, where a different nurse was brought on board, and they didn't differentiate between 1% and 2% vials of lidocaine. So in our office, we only use one type, not both, in order to obviate that obvious major potential difficulty. That's just something to keep in mind that the staff could actually pick up on. This is just our common solutions. Solution A is the workhorse one that we use for our local cases. D is a smaller concentration for sedation cases, which helps the anesthesiologist have a very low intraoperative demand for analgesics, as well as having an excellent postoperative exit from the anesthesia with good analgesia. Solution E is a slightly more dilute version of A, so we can use a little more volume for our trunk cases. But for the docs, I use a lot of face and neck. I use A 100% of the time.
Okay, so for post-procedure, antibiotic ointment, if necessary, other suggestions here. I did give a couple of resources for compression garments. The Mirena group tends to have really good quality garments. They might be a little more expensive than the other ones. There are a lot of really good garments out there. And again, physician dependent, whether, you know, on longevity of garments and types of garments to wear.
Maybe I'll go through a couple of videos that might be helpful. Just kind of galvanize a few things. This is a head and neck case. We'll skip the markings. Okay, so the tumescent part here, I'm going to pause this for a moment. So I'm using the standard solution A, which is 1%, or it's equivalent of 0.1% lidocaine, and 1.5 cc's of 0-1,000 concentration epinephrine, a little bit of bicarb. That's a 30 gauge needle on a 10 cc syringe. But we in the States like to use 14 gauge needles for puncture on the small cases. And we and as you can see, she's awake. I prefer to use it's a 14 gauge hollow needle. Some people use a skin punch, but I don't think it's necessary to actually remove dermis. What I'll do is then start the infiltration with a 30 gauge standard spinal needle, Becton Dickinson 3.5-inch yellow hub here in the States, and then switch over to a standard 16, 18, or 14 gauge blunt infiltration needle, which is pretty standard. Let the hydrostatic force. So I think what the staff here really has to be aware or just observant of is making sure that there are no air bubbles in the line, obviously. I use a peristaltic pump. Some surgeons like to use hand pumps. And once we do the RF energy, naturally you're going to make sure that the temperature monitoring is adequate. We all know that the doctors are going to be focusing on the operative field and listening with the audible feedbacks that are unique to the InMode devices, which is great. But it's always good to have a second set of observers double checking once in a while on the screen as we're doing the heating, and making sure that the surgeon is doing it continuously. We don't advocate in general the stamping technique. We advocate the continuous. It's always safe to heat on withdrawal if necessary, but if you feel comfortable doing back and forth, of course, we'll do that. And then most of us will suction after this part, which I will skip. I'll go to the next one. Okay, so this one's a chest case, just to give a little bit of color with a trunk case. So
Right. With regards to the last patient, any
Mhm.
tips or tricks that you can have to get the patients to sort of maximally extend their neck so that it's comfortable for them on table and for, you know, that half an hour or so while we're doing the procedure?
Great question.
great question.
So we'll
Thanks.
tip depending on what type of OR bed or patient bed you have, we'll either put like a towel roll behind the shoulder blades so that they can get a little bit of hyperextension, or if the table actually itself, the head of the table actually comes down, then we'll get them in a little bit of hyperextension. But that really helps to give, you know, the physician good access to the neck.
Right. That's if you have the spa tables probably only go about 180 degrees. I use an OR table because only in New York we have limited real estate, so we use our main OR for everything, and it's just a standard hydraulic AMSCO OR table that has the hyperextension. You're doing a neck case or a facelift, it's the same thing. We use a beach chair facelift position for those of us who are familiar with that. So I think the nurses who do a lot of facelift assisting will know exactly how to prep. I tend to over prep. I think that varies, but I think there's no such thing as an overly good sterile field. And I'll use standard towels. I'll towel out and sheet just like as it were a face and neck lift. That's a good question though. But for those of us without the OR table, at least it's towel trick. It works very, very well.
Thanks for that. And now with regards to this video that you're showing, I saw for a second there you were using the Vaser system together with this.
Yeah, so that's that's
Vaser before?
Yeah, that's outside the scope of our discussion, but in general, for fibrous tissue, secondary cases, male gynecomastia, anything that you think you're going to have a very, very hard time, Vaser is a good adjunct to RF and liposuction because it helps to really soften up the fibrosity of the recipient site. And I really enjoyed using that. And it actually makes the RF work better, in my opinion. One of the tenets of gynecomastia surgery naturally is to disrupt the IMF. So that helps assist that. And that actually makes the RF deposition of the energy, so to speak, over the IMF because you're trying to make the inferior pole of the male chest go down rather than up as in a female breast. That helps to really develop the lattice recipient site. It makes the RF much more well received, if you will, for the tissue. But those are good adjunctive technology. This is just local excision with this patient still awake, but I'm going to skip that for today. And we all know how to do that. Okay. Treatment parameters. Lisa, you want to give a few thoughts on this? This is actually what a doctor is just going to tell you, as you know. But from your perspective, what are you looking for?
Well, there's screen's going to look totally different than that, but you know, basically you'll want to know what the typical parameters are so that you can help guide them. That'll be all something that will be slightly different for you guys. If you're interested in typical temperatures that we use, is that something you guys would be interested in?
That's usually something the doc will tell on the way. It's like, oh, may I have 39.5 and 68, and then my nurse knows exactly what I want. And there's only a couple of sets of numbers as those of us who do a lot of these. You have a head and neck number, you have a body number, and that's pretty much it. Maybe a couple variations within for different body areas, but the nursing staff gets very well acquainted with that very quickly.
Sorry, I have a question regarding
Sure.
this last slide. Are you looking at the energy, or are you only looking at time when you are controlling the endpoint of the procedure?
Great question. That might be a little. Lisa and I agree on this, but that might be outside of scope. But just to answer your question quickly, some folks like to do kilojoules. But I prefer. You prefer as well, Lisa, right?
Temperature.
Time and temperature. So the way I look at it, just quickly, if you're heating a loaf of bread or a cupcake, right? You have to have it at United States like 425 degrees, I guess, whatever in the oven. That liberates a certain amount of kilojoules. But if you're making a giant loaf of bread, you still have to get it at 425. So the amount of kilojoules to get that change in the biochemical structure is going to be a lot more for the big loaf of bread than a little cupcake, right? So I don't hang my hat on kilojoules, although I use it as a marker for the following: bilaterality, so that I'm relatively same from the left and right sides. And secondly, if there's a minimum number of kilojoules, such as a face joules, that I think it heats up very quickly, I think you need to have at least a minimum kilojoules. Otherwise, I'll say I'm going to try to heat the internal temperature and external temperature, for those of us who have that device, or just the external temperature, up to a certain amount, certain threshold temperature, say 38.5 centigrade. And then I'm just going to keep it there, continuously moving the wand to to effect that heating for that particular treatment zone, which we all know ends up being like a pizza slice because it's an arc access point in an arc. And that pizza slice, we want to get nice and even, heated for X number of seconds, what the practitioner will deem appropriate. So I'll give you an example. In the neck, I want to do 8 to 12 kilojoules total, and I'll divide into 4 little zones. And each pizza slice, I want to do 3 or 4 kilojoules, and I'll just keep it going like that. I don't want to just get the water at 100 degrees centigrade boiling and then throw the pasta in. We don't turn the water off, right? We don't turn the gas off. We actually keep it boiling until the pasta is al dente, if you like a little tougher, or very mushy, if that's what you're into. But it varies. But that's a good question, but we digress a bit. I hope that was a little helpful.
Just to precise, because starting doctors, they are working a lot on withdrawal, and every time you will get to the end point, the time will stop. So you basically don't know how long you were treating the patient total, because when you release the foot switch, the time will start from the beginning. So how do you, when you look at the temperature, how do you control it if you have a withdrawal technique?
So I'll answer this one. So the best way to do it is you have the audible sound on your device, right? That tells you when you're at temperature.
Yeah.
So once that sound is consistent through the entire treatment area, that's when you know that entire area is heated up. So I'll usually go through that treatment area a couple of times and make sure every single part of that treatment area is up to maximum temperature.
Okay.
Does that make sense?
Okay.
So it's
so
more.
You reach the sound and that's finished. You don't continue for additional minute.
Well, you make sure that it's consistent in that whole entire area. So I usually go over it a couple of times, because while you do that, you've probably already got to 30 or 60 seconds of being at temperature in the entire area. Does that make sense?
Yes, absolutely.
Yeah. Something that might be helpful as a teaching tool for the newer users is an infrared camera. And I don't know if you know, it has a heat signature, which is very visual. It's very cool to see a visual. And they're inexpensive, and you can buy them and you stick them on the end of your phone. And that way you can determine the following: how efficient the practitioner is getting the heat. Number 2, how consistently the heat spectrum is. You don't have a hot spot or a cold spot. And number 3, you'll see how long that the heat is being applied.
I use that in most of my in practice. I don't typically use it much anymore, but in my trainings, I use it very consistently, because especially if you're doing a larger area, like an entire abdomen, it's a great way to say, you know what, you didn't quite get that area, and it'll tell you what your external temperature is at 40 degrees, 42 degrees. It will give you a color of the temperature, so you know that it's consistently done. So it's a great teaching tool. And ours, it's called FLIR.
We can give you a link to it.
I can give you a link
buy
to
it on
that.
Amazon
Right.
for a few $100s.
Sorry to interrupt. We have 3 people waiting to get into the
Oh,
meeting.
yeah.
Can you please accept them, please?
Of course.
Thank you very much.
I have another question about the temperature that you were saying. So instead of stopping at the sort of ding, 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 I should instead get sort of that consistent ding, ding, ding over an entire area before I move on to a new area.
Exactly. That entire area should be triple beeping. And I sort of tell the physician, that's your signal that you're done. Once you hear that triple beep in that entire area, then you can move on to the next one. Now, the one pearl to that is sometimes, well, actually you only have one temperature. So for us sometimes you have to do a little bit of back and forth, because one temperature will be up, but the internal will be up, but the external won't. But you guys don't have to worry about that.
No, we have from in Hong Kong we have a double sensor handpieces.
Oh, you do? Okay.
I noticed several times that the system started to release the the signal that we reached the temperature on the external handpiece, but internal was still at 55 and we were at 68 cutoff. So it was a little bit confusing what we should do, because the sound was good, but we see that inside the temperature is not good. So is there any, would you use a cold gel to cool down the surface of the skin in this case so that we achieve the right temperature inside?
There's a couple things you can do. One is as does Dr. Chia. Is everyone let in?
Yeah, Hilda, did I let them in? Are they in?
No, they're not in yet.
I don't see them here. All the participants are in. I only have 9 folks here. Do they have the correct link? They may have the old one. Make sure they have the new one. Exactly.
Yeah, thank you.
Thank you.
So there's a couple different things you can do. One is I will typically work on the internal temperature first. So your cadence is very slow in the beginning because you're getting that internal up. So if you can get that internal temperature up, then you won't get cut off too soon for the external. Now, sometimes if it's a very thin layer that you're working on, sometimes the external gets up there really quickly and you have to just go to an adjacent area, let it cool down for a little bit and then come back. But it's really about timing. Just play with it a little bit. If you're moving really, really slow, it's much easier to get that internal temperature up first. But if you're moving really, really fast, you're gonna get that external temperature up a little more quickly. So does that make sense? It's if you're having difficulty getting one temperature versus the other, just switch the timing. So either move a little faster or move a little slower, and just that little movement can make such a big difference in reaching the threshold for either temperature.
I think we can address that when we open all the packaging again.
Yeah,
but yeah, that wasn't actually the focus today. But we're happy to do it at the end or in the middle.
No, but that's a good point.
Yeah, it's an excellent point. Yeah, that's actually probably the most common thing.
It's common in training. Yeah. Okay. So always gel. Especially new users will forget that they have to have gel. So sterile ultrasound gel. I'll go through sort of the setup once we switch over to the.
Okay. You want to keep the practitioner honest, right? Your guy's job is to make them look great and the patient does great. So in trunk cases where it's a relatively thick penis and a lot of fluid, I'll start deep because especially in the local cases where patients are awake, there are fewer nerve endings and it's less richly innervated, and it arborizes obviously more densely as you get to subdermis. So I'll do the bulk of the injection deeply and then go into intermediate and superficial in that order. That way that the lidocaine can kind of do its thing. You have a little bit of a hydrostatic effect, and the lidocaine can get to the subdermis then in the awake patient. If they're asleep, it doesn't matter. Fanning, making sure, 3 things I tell the practitioners and then you want to keep an eye on is, number 1, keep it moving, dummy. You don't want to have the instrument stopped. You also want to only heat the area. You don't want to heat proximally to the axis incision, just like you don't want to over liposuction within a centimeter or 2 of the axis incision. Number 3, and keep it deep. You should always have a little bit of water and a little bit of tissue between the under surface of the skin and the internal probe. Anything else, Lisa? Anyway.
No, that's good.
Okay. Energy per zone.
I did put energy per zone because it just gives you a landmark. But again, it isn't the be all end all, but it just gives you some sort of reference point. If you're doing an abdomen and you've only got to 10 kilojoules on the entire abdomen, probably didn't reach temperature, in either your internal or external. So just as sort of a reference point. Okay, keep going. Typical area. So that's under eye treatment.
I think that's Dr. Ravati, and this is my partner here with an armpit.
This is your internal electrode. It's got a cutoff between 60 and 75, and this is your external electrode between 30 to 42. Now, I've always positioning my body or my hands where I have direct control over everything. As you can see here.
So you hear that the TSP. Helda, does everybody have TSP over there? Or do you all have the, okay, great. So basically, yeah. One source of frustration from the practitioner's end can be that the TSP is getting triggered too frequently. And that means in small, tight spaces where it heats up very quickly, you can have the TSP trigger. So just like you said before, I might take a cold lap pad and put on external, go to the contralateral side, heat that up, put a couple of kilojoules in and come back and do the first side again to ensure that enough energy has been imparted. Remember, joules, kilojoules is just a measurement of work. And you actually want to work the tissue over an amount of time because that's how it works, no pun intended. And you don't want to be frustrated or have the doc get frustrated, but the thing keeps shutting off.
So one troubleshooting that I've had is sometimes if there's not enough tumescent in that area, especially with this smaller handpiece, the Accutite, you'll continuously get temperature surges. It probably means either A, they're outside of their area of tumescent, or B, they didn't use enough tumescent. So if you're constantly getting that temperature surge, either redirect them to, reposition either, more deep, or encourage them to add tumescent. Those have been the two reasons why you get just continuous temperature surge.
I have a question regarding that case just now. How do I choose whether to use a Accutite or a FaceTite probe in an area like that?
So I would have used the FaceTite, but we were demonstrating the Accutite device. So I would say if it's an area like the size of your hand or more, then it'll be more efficient time-wise to use the FaceTite handpiece. But if you're doing smaller areas such as like nasolabial folds or under eyes or, very small pockets, just a tiny submentum, then that's when I choose to use the Accutite. What's your?
Whatever fits the area. If it's a small area, I use the Accutite, tight corners, absolutely, and a FaceTite. Just as a general background, we're all aware of the different power potentials of the handpieces, but between the Accutite and the FaceTite, they're basically identical. The Accutite is 16 watts and the FaceTite is 20 watts. So for all intents and purposes, they're similar in power. However, because the Accutite is so much smaller in the area that imparts the energy, in my opinion, and in clinical practice, and what I observe is that it heats up very, very fast. So I'll actually use a FaceTite, and I think you do too, Lisa, that when in a space, like if it keeps heating too quickly, I'll use a FaceTite because having a slightly larger external probe surface area and a slightly larger internal probe diameter, it actually liberates, cooks the tissue, if you will, a little bit more slowly and more evenly, and it's more predictable.
Yeah.
So if it's not too cumbersome, I'll use that most of the time. Just like you said, here you use a FaceTite, I probably would too.
Okay, thank you.
Great catch.
Yeah, good question.
Complications, obviously, being too superficial, coming out of your access port. Those are the two main complications. I think I have a couple pictures. You can go to the next slide. Right, you don't want them to tent that tip up. Right, I always try to tell them, it's sort of like a hot poker. If you have that tenting up against the skin, you will get a thermal injury.
You want at least 8 to 10 millimeters of tissue between the internal probe and the undersurface of the skin. That's too superficial. If I had a guess, that's only like 2 or 3 millimeters. In the face, you say, how am I going to get that much thickness? They say, well, you can do a couple things. Well, we accept about 5 millimeters or so around there in the face and neck. But they also, just like Lisa alluded to earlier, in a different scenario, just put more water in. Or tumescent.
In.
Yeah. I always say water is your friend. Yeah.
Especially a thin patient, just encourage more tumescent.
Right.
It'll keep them out of trouble.
Yeah, a lot of practitioners don't put as much in the face and neck. I'll put in 300, 350 cc's in a face and neck, and they look like a bullfrog, sure, admittedly, but it goes away. It's just saline. But water is your friend for the following reasons, in my opinion. Number one, it ensures that you have a safe distance between that and the under surface of probe. We're going to keep harping on that. Number two, water acting as a heat sink, because it has a high specific heat, will also distribute the heat energy secondarily. So you get an RF effect, direct RF effect, and then you get a secondary heat effect from the surrounding tissue and fluids, mostly the water getting heated, and you're going to get collagenesis from those two things.
Mm-hmm. And this next picture, go to the next one actually. Yeah, so that will show what'll happen if they're too superficial. And you know, those actually will go away, but it takes, you know, 6 or 8 weeks for them to go away. You don't ever want to see that. That was a problem of not enough tumescent.
And also where it's thin in the face and neck, we see that if you heat too closely to the axis incision, say we pretended it's around the lobule, and you want to say this is the corner is where the axis incision. You don't want to heat anywhere closer than 1 centimeter. So there's a little arc of non-heating. Sometimes the newer practitioners will actually heat all the way back here, like so, and you can get a little bump here. And I'm sure some of us have seen a bump here. That's basically heaped up collagen, a second-degree burn that will go away, but just like this. But it's annoying, and you want to avoid that.
Yeah. All right.
Hello, can you hear me? It's Neil from the UK.
Welcome, Neil.
Yes,
how are you?
yes.
I'm good, thanks. Thanks very much. It's really good. Can I ask you, do you do combination with Morpheus 8 after you've done Accutite, face tight, body tight?
Yes.
Almost 100% of the time.
Yeah.
Unless I run out of a tip.
If we can, yeah, 100% of the time, if we can, yes.
My question is, we do too, is complications with that, potentially heat upon heat, the pins creating heat where we've already curated the damage, the heat with Accutite, body tight or face tight. And we've had some what we call red erythema marks, pin marks, and I think it's because the energy is too high, but just want your comments on that, how we can reduce that.
What types of energies are you using for Morpheus?
It depends on where we're using it, but let's say we're doing a face neck tight, energy levels, I try and keep it to 30. They were going to 40 because the patient's already tumescent up.
Yes.
But I felt that was too high. I've seen it not happen so much now, but we do get occasionally, especially around the arms as well, these pinprick red marks that take a very long time to dissipate, a long time.
So it's typically either an energy issue, so too much energy, or a technique issue. You know, not enough pressure, or sometimes the practitioner's moving not as fast as the delivery of energy. So yeah, it's probably likely an energy issue.
Presuming that all the technique is fine, just as comment on you going higher with the tumescent, I agree with that because water is a heat sink, so it may dissipate some energy. That's as an aside. Specific to your question, the software that's being disseminated now has been upgraded. So we'll make sure that all the end users have the most modified upgrade, because as you know, the way the Morpheus works, which is really neat about it, but also adjustable, is that the anode and cathode are all in one tip. You can actually change the waveform. That's beyond my comprehension, but the CTO is a very smart person, and he actually can modulate the software so that the heat doesn't kind of hit it as so much. I used, in the first generation devices, yes, occasionally I see the little L where if my technique were not perfect, and I was going quickly, you can get that temporary L with the red, and then secondary with the redness that you anticipate. But then you say, gosh, I want to see the redness, but I don't want to see it for 2 weeks. I'd rather see it for 2 or 4 days. There's a couple of different things going on.
I do let patients know, though, that on the body, they're going to see those red marks much longer. I mean, I've seen them last on the abdomen for 4 to 5 weeks, and that's okay. I mean, I just really always prep them beforehand that it's not going to go on the face. It'll go away within a few days, but on the body, it's going to take much longer. And that's why, you know, avoiding sun is so important on those procedures.
Also, Neil, we do a lot of body. So I would say face and neck, if I do Accutite, face tight, neck tight, 100% of the time I'll do the microneedling with M8, and I'll do most cases of triceps area, the bat wings, inner thighs, medial thighs, suprapatellar skin, and plus minus maybe 50-60% of lower abdomen if I'm doing body tight there. I just throw the M8 in because I feel so strongly that it's a benefit to the patient that we package it as such, and we tell them ahead of time you may have a little extra redness, but that's a good thing to have because it indicates a positive sign of neocollagenesis and appropriate inflammation.
Yeah, absolutely. We do the same here. We really like the Morphus 8 because it gives the patient confidence during the healing process. They see the contraction superficially.
Agreed. Yeah,
Right.
yeah, I totally agree with that. Second bite of the apple, if it were, as it were. With
Exactly.
the
So with that, yeah. So the energy level, are you saying that we should reduce the energy level on the Morphus 8 when we do a combination treatment or not?
I do 30. Yeah, I do 25 to 35 depending on indication, but 40 is a little hot.
Yeah.
I think, for me, for my taste, I'm not being critical at all.
On the face.
Yeah, you did tons of. Lisa does a lot of standalone M8s. And what's your protocol in terms of timing and how many treatments and average power?
So I'll do, a series of 3 treatments. If they're having face tight, I'll do the first treatment, with face tight, and I might use a little more energy on the face tight because I know they're too messed. But I don't typically turn it down if they've had face tight as well, because I feel like I'm working in 2 different levels. Face tight, I'm working in this direction. M8, I'm working in this direction. So,
Yeah.
Which is great. I love that you're getting from 2 different vectors.
Okay, sorry.
Thank you very much.
Sure.
Pleasure.
Post-treatment, I think this is
Pretty self-explanatory.
pretty self-explanatory. Yeah. This is something that's sometimes physician dependent also.
I do want to
just
mention,
wanted to show a setup. So.
I do give a little antiviral for patients who have HSV prophylaxis when working around the periorbital area, the mouth area, if they have a history.
If they have a history, yeah, definitely. Okay, so these are common questions that the staff or patients will ask. Go ahead and keep going.
Do you want to just actually just a good time to go ahead and do the setup. Please, while we're doing that for a few seconds, feel free to ask any questions as we're doing this. Let me see.
Go to camera 3.
3.
Yep. Perfect. So this is a typical setup for, like a small face tight case. Hopefully you can see this here. Really, you don't need a lot of equipment. I would add a couple of towel clips on here. And again, this obviously would be all sterile. It's not today for these purposes, but I'd like to add a couple of these. This isn't a towel clip, but we'll pretend like it is a towel clip so that you can hold the handpiece on there. A half sheet here, of course, gown, towels, ultrasound gel, and then, the access. Usually you'll put a little bit of local in for the access site. And then this is a spinal needle that we use to deliver either with an infiltrator or, with a hand pump. Marking pen. And the only other thing I don't have on here is just 4x4 gauze so that you can help retract for the case. And then the handpiece.
There's a question about retracting for the doctor when you're doing the case. What are your thoughts on that? Yeah,
always. I mean, especially if you have lax skin, you always want to make that treatment area, basically tight so that they can easily pass the instrument without getting caught up on, lax skin. What questions do you guys have other than what we didn't cover?
You can go ahead and plug something in. Tell us if this is too basic for everyone, but we're just going to go ahead and do it just for inclusivity. So,
you see, we're on camera 3 here.
Yep.
All right. Can you guys hear us okay?
Yeah,
That's very good.
Okay, great.
All right, great. Do you guys have any questions?
It's Neil again from UK. So pre-tunneling, what do you use to pre-tunnel?
Great question.
Yeah, I just use a lipo cannula with the tubing on off suction. Having the tubing on the back prevents a mess because stuff will come out invariably even at low pressure. Secondly, you don't want to be suctioning at the same time. At least I don't. And then thirdly, you don't want to use the actual body type, face type, AccuType Pro because the internal thermistor is quite sensitive. Even if it has the coating, you don't want to damage it. Oh, and
So-
for those reasons, yeah.
Yeah, so I like to use something that's similar diameter than to the device that we're using. So if we're using AccuTite, I use a very small, cannula. Face tight, I like to use similar diameter. Of course, I'd use a larger one if this was a body tight case. But can you guys see? This is a typical cannula.
Yeah. Stuff that most ORs have already. We like to go as lean and mean as possible, autoclave what we can, minimize the disposables, and then, just maximize your utility. Just like any OR, right? Great. And did you want to?
I think you're all familiar with how to attach and use the device itself, correct?
Yes.
Yeah.
Yeah.
Right.
Can I ask some question? When you do the tumescent infiltration for the face, do you normally use a pump to do it, or you prefer to do it with a syringe, like manually?
Both. I work with
you wanna
physicians
grab that? Yeah.
who use both. Actually, so what I found recently is, can you see this? So this is a great little hand pump that basically you spike to the bag. Actually, I can open this. You spike it to the IV bag, and it will sort of self-inflate. So this part goes into the bag.
I'll hold that.
All right, and then you can attach either a spinal needle or we use those mesocaine needles also, depending on if we're doing Morpheus body, we use this a lot, and then we use this as a spinal needle to infiltrate it, so that hopefully you can see that okay.
For those of us who use breast augmentation with the old saline implants, it's the same thing where you have the three-way soft cocking to fill the implants.
So this will self-fill. So this is really great for Morpheus, but also good for, just small cases if you're doing the face. So, but I'd say half and half. Some use an infiltration pump, some do it by hand.
I use an infiltration pump 99% of the time.
I think it's.
And you want to get one that has a low flow rate option, because if they're awake, the slower you go, the better it's tolerated, because the rate of distension of the tissue is equivalent to the rate of stimulus or pain. So it's like barbecuing here in the States. You want to go low, deep in tissue, and then low and slow, like barbecuing when you infiltrate.
Do you guys have access to InMode University? Dr. Chia and I have archived all of our live streams there, and we try to go through, these little tricks that we use for our cases in all of those. But it's a good resource, InMode University.
Yes, we have access to it. Yeah, thanks.
Okay, good.
Yes, we do in the UK.
Okay.
So any other questions from anyone that we can answer?
May I ask, do you just use the infiltration pump with the vaser, or do you use something else?
Well, the infiltration pump is for the tumescent. So
Yes, but I mean, the vaser system comes with the infiltration pump.
They have a system, yeah.
Adjustable.
I'm not familiar with the other than that device itself. That's just an ultrasound generator. I do believe that they have an infiltrator or something like that. That's a separate piece, but you'll have to contact your vaser person, I guess, whoever's a local person.
You can buy the pump just individually.
Yeah, well, I use off the rack. There's a company
Wells
called
Johnson.
Wells Johnson. There's Byron, which is a subsidiary of Allergan. Those kinds of things.
Okay, thank you.
Sure.
Hi, it's Neil again. Window and face and neck. we are really, really conservative about staying away from the mandibular facial nerve. And so we will do that manually, infiltrating, because we just do not want to create any, we want to be in control, basically.
Certainly.
What's your comments there about that? Because it's there's so many causes that can damage that nerve, be it infiltration, be it face-type, neck-type, could be pre-tunneling, it could be anything. But
we have an actual episode on 2 different ones in what Lisa alluded to, the resource center, that obviously the marginal branch of the nerve has a somewhat predictable path, but did not, as my old anatomy teacher said, it's not obligated to be where we expect it to be, right? So to be safe, we do something called a no-fly zone, and that's actually illustrated by computer imaging that we have on the site, as well as explained much more in detail in one of our InMode universities. And you can, if I refer you to Dr. Rod Warwick's, and Dr. Sherelle Aston's videos, and Dr. Aston and a group of us, myself included, went down to a dissection lab and actually did that. And so basically you drop a line from the modiolus to the corresponding line here. We just mark 1 centimeter anterior and 1 centimeter, actually opposite, anterior and posteriorly. And that area is a no-fly zone. Excuse me. You don't want to actually heat from there. And we don't actually go retrograde in this way.
But as far as the infiltration, we use infiltrators to infiltrate that area all the time. I actually think sometimes the infiltrator gives you a very good plane to get into, because if you're in the right plane, that should infiltrate pretty easily. And we don't have issues using an infiltrator and worrying about the marginal.
Yeah, I did get what I thought was a stretch neuropraxia in about maybe 1 out of 500 or 600 cases, average incidents, and that's about par with plain Jane liposuction of the neck. And knock on wood, it goes away, as expected within 4 to 6 weeks. It's a grade 1 neuropraxia. And certainly it's not a heat injury. If it were to be RF'd, I think it would have been a much more injurious situation. That doesn't pan out clinically. So fortunately, never had a, knock on wood, a permanent problem with that. But when I was less experienced, I was using a lot, even more than I do now, tumescent. I think it was blowing it up really a lot. And even if I was avoiding this area, it was just stretching it just from the proximity to the detention of the fluid. And I think that was, and then plus the lidocaine seeping into the neurolemma probably, caused, I think a good number of patients will have a little bit of droop, just for 24 hours from the lidocaine. For as far as the ones that last a month or so, it's very, very rare, fortunately.
Yeah, I totally accept all that, because that's what we see. If anything, it's temporary. But I like the pump thing. I'm trying to work a way around, help the operator with the confidence, is that you probably get a uniform flow rate.
Extremely, but you need to get a good one. Don't get those Amazon ones for like $100. I just got another Byron, B-Y-R-O. It's called Easy Pump, Easy, spelled Easy Pump, and you can get them secondhand pretty reasonable. I have nothing to do with the company. I just happened to buy one last week as a backup. And another one was a Wells Johnson, which is
consistent.
It's an Arizona company. And
you can turn it down really slow. I say if they're new users, turn the volume down really slow. It'll take a lot of extra time, but it'll keep them safe.
Yeah.
Face and neck, when I start, I'll go as slow as 50, which is, I think, 50 cc's per minute, which is super slow, to start 100, 150 and then go up. And I like using a spinal needle, which is a sharp instrument, which could be criticized. But if you feel comfortable with the anatomy, it's okay. But then larger areas, I just use a bigger blunt needle, just blunt cannula, just like that, most of us do.
Yeah, that's what we do. Can I keep on this subject? Regards to the tumescent levels, face neck tight, more and more confident. I'm seeing less tumescence because they like to see the contraction quicker, and also there's lesser downtime, less confidence. They bloat the face up more and more. But the outcomes are still the same. Would you agree with that? And
yes.
What are your comments?
As long as you're reaching your temperatures, I think the outcomes are the same.
Yeah.
The key is to keep them safe. So use enough. It might take a little long, the more tumescent you add, sometimes it takes a little longer to get up to temperature, but it's okay, it's still safe. But as long as you're reaching temperatures, the outcomes, I believe, is not
Yeah,
gonna
no,
change.
they're equivalent. I mean, we have practitioners use half the volume that I use on average, and I think they get great results as well. Actually, they might heat up the tissues more quickly than I do because the
Right.
water is a heat sink, but I'm okay with that couple extra minutes because, like I said earlier, I like that it separates things out. You have a nice separation between the fat and the dermis. You know exactly where the internal probe is, and also it distributes the heat with that's liberated secondarily very evenly. And this brings up a good point, Neil. When we do trainings, let's say, well, I prefer in the beginning to teach folks, and Lisa, you do, when you do your training, same thing. I go 2 MES, RF, then lipo, especially in like a trunk where there's a lot of it, rather than some folks will say, well, gosh, I want to waste my time heating the deep fat in the water I'm going to take out anyway. Say, I agree with that. But then they'll 2 MES, debulk suction, RF, and then fine tune suction. That's totally fine. I think you can do that. But in the beginning, as you get comfortable with that, I would do RF, then suction for the following reasons. Number one, the turgor of the tissues makes it a lot easier to pass the instrument. So you're not trying to pass the instrument underneath a floppy tent, so to speak. Secondly, if you have a fibrous patient, like a male or secondary liposuction in the trunk especially, I think that extra turgor helps to pass the instrument. Because sometimes a face site and acutite can be a little, they're so thin, which is great, but they also not as stiff as a body tight, right? So you may have a whip effect that you don't want. Thirdly, if you're doing the, as you start with the heating on withdrawal, that's great. But if you want to be more efficient and go forward, I think it's a lot easier to do it when there's water in there. And then the other reasons we talked about, the heat distribution is key.
Thank you. That's really good.
All right. Well, Hilda has our contact information for both Lisa and I. We're happy to email back if we can, those kind of things, if they have general questions. And if there's any follow-up, we'll be in touch with Hilda. Like I said, we encourage you to look at the Indimo Resource Center. There's a lot of good stuff on there. Anything else, Lisa?
And we'll be happy to send a copy of the PowerPoint also.
Yeah.